Okay, so as before, we want to encourage our audience, if you have questions, please go up to the microphone. We'd like to take your questions as well. We have a lot of questions from the virtual audience, and for each of you panelists, feel free to jump in on any question you'd like to weigh in on. I want to start off with a question. One of the first questions we received was on the issue of lupus anticoagulant, Michelle, and you showed us that even 25% positive was important. The question is, how often should we be doing lupus anticoagulant assays in our patients? Oh, you're muted, Michelle.
I'm not muted.
Okay, now I can hear you. Go ahead.
Okay, good. So, Jack, there isn't a best answer for that. I would suggest checking when you first meet the patient, checking at the time of flares, and then checking when you hit a decision point, such as a patient who's about to become pregnant, that kind of thing. Right now, we do it the other way. We check after something bad has happened. And even if it's negative then, it might have been positive before, and it may be positive the next day. It's the same problem we face with anti-DNA and low complement, that when things fluctuate, you only pick it up if you check frequently.
So I think in keeping with what Clay was talking about, the question often comes up, how often should we be doing more widespread monitoring of our lupus patients? Because I think there's quite a variance in what people are doing. I think a lot of people might get, depending on the medicines you're getting, they might get quarterly, blood counts, urinalyses, whatnot. But as far as complements and autoantibodies and now even lupus anticoagulant, must it always be tailored to the patient, or is there a smarter way of doing that?
Well, Jack, I think you have to tailor it to the patient. I think my one take-home message is if you're going to check any antiphosphate antibody, check lupus anticoagulant. And I think that if a lupus patient is coming in for their routine visit, of course you're going to want to get a urine protein to creatinine ratio, because you never know when a patient's going to develop lupus nephritis, and obviously they're asymptomatic when they develop it. But in terms of other things, I can't imagine, checking everything on every patient. But perhaps we should be more vigilant about checking cardiovascular risk factors. So I think the worst thing about telemedicine is we miss the blood pressure. The one place where we can really make a difference and we don't know. But of course, I think, we should be checking on their other cardiovascular risk factors, such as their cholesterol.
So brought up, I think, by two of our speakers was the issue of compliance in lupus and how the numbers are sort of shockingly low and disappointingly bad. So Maureen, do you have a way of dealing with that, or how do you get those numbers back up?
Yeah, of course, that's one of our biggest challenges. But I think I found that the more you open up the discussions with your patients, I think that the better the dialogue is, and the more likely patients are to be compliant, or at the very least to tell you when they're not taking their medications. I know Michelle checks hydroxychloroquine levels very frequently. I think that, if you have levels to check, that can encourage compliance as well. So that can almost be a tool just as much as it is a helpful laboratory, that can help you guide your treatment. So again, I think the most important thing is really the dialogue with the patient. I don't think any patient's going to take a medication if they haven't bought into the reasons why you're prescribing it for them. So I always encourage my patients to, keep asking questions if they have them as they go along.
So Jack, what I would add to that is I want to quote President Ronald Reagan: trust but verify. I think we have a huge problem. We give our patients medications for prevention of later bad things. And this is tremendously important in lupus nephritis, right? The patient doesn't feel bad. And we give them medications that have side effects and expect them to take them. So I think a lot of this is explaining to the patient who has lupus nephritis that once you lose a nephron, you never get it back. There's no do-over. I'm afraid some of our patients have too much faith in us that we can undo any bad outcome. And I will sometimes say to patients, don't drop the ball. or I'll tell them that I'm the coach of their team, but they're the quarterback. So the reason I like blood levels is then the discussion is quite objective. The patient has told me that they are taking their medication, and I show them the computer screen and say, well, look, you've missed so much that you're subtherapeutic.
So let me just ask I'm going to come back to you about blood levels, Michelle, in a second, but let me ask Clay and Maureen, do you measure or have you thought about measuring hydroxychloroquine levels in your patients? Clay?
It's a good question. I don't see that many patients that I have on hydroxychloroquine personally, but I think if you ask somebody like Melissa Costner or Natalie Wright, they probably would check that. I know that they actually have done that in a number of cases. I think it's a reasonable thing to do.
Yeah. Maureen, what do you do?
Yeah, I've only been checking in cases where I'm not sure if patients are taking it or if I think that it doesn't seem to be working as I would expect it to. I haven't started checking routinely in all my patients like I think Michelle has. But I think, as testing has become more available, I think that's more of an option.
So Michelle, at ACR, you had a presentation on this that the target level we should be shooting for was over 1,000, 1056, 1066, as opposed to 600. And could you talk about why you chose that? But then talk about also what's the downside of measuring levels, and then do you push dose to levels, and then do you violate dosing restrictions based on weight?
Okay, so there's a lot of that question, Jack.
Sorry.
But let's start out with the guidance, which was from ophthalmologists without any rheumatology input.
We remember that great debate, yes.
Yes, where everybody is going to get 5 mg per kg. And the problem with that is that we know, we've proven, we've published that there is huge personalization issues here that are probably genetic, where even if you give everybody that dose, you're going to see a huge range of blood levels. So I want blood levels first to check for adherence, because if the person's below 500, they're missing probably 50% or more of their doses. And because, as you mentioned, we want to hit 1,000. Now, why? Well, Natalie Costa-Doet showed using ROC curves that 1,000 was the ideal dose for controlling disease activity, preventing flares. But where I went further was to show that 1,000 is the dose you need to have that antithrombotic benefit of hydroxychloroquine. But then there's a third reason. I don't want anybody to get retinopathy. So the next thing we showed was the patients who go on to get retinopathy are in the upper tier of hydroxychloroquine blood levels. I hope that's no surprise, right? So I don't want people to be above 1,500. I think there's a sweet spot. I want the benefit of hydroxychloroquine, and I don't want toxicity. So I don't take away from the ophthalmology guidelines. I completely buy into them, how important it is to do OCT every year. But I question this idea that we dose by weight and we ignore data.
So, Maureen, you mentioned some of the newer data and some of the newer agents. You talked about voclosporin. Does any of our past experience with calcineurin drugs inform the utility or how we're going to use voclosporin? Because it's a brand new drug, just came out, indicated for lupus nephritis. Again, but does past experience tell you how you might use it going forward?
Well, I think that, we're still finding our way with when to start some of these newer agents. But I do think that, we can certainly look to the literature that we have looking at tacrolimus. And there's been numerous studies that have come out of Asia that have really shown that perhaps adding tacrolimus in addition to mycophenolate could be helpful for nephritis. So, I'm starting to think about that in my patients, especially those patients that I think may be at higher risk for progression to end-stage renal disease, and thinking about starting that earlier. So again, I think that we'll see as we go along and get more experience, but I'm excited that we have new agents.
Hey, Jack, would you mind if I ask
Jack,
the panelists a quick
I could go
question?
even further. I want to go further than Maureen on this one. I think we need a paradigm shift in lupus nephritis, because right now, fewer than 40% of our patients achieve a complete renal response at 12 months. Mm-hmm. So the paradigm shift means we don't wait for the person to be a non-responder and then decide to add something. When we see a bad biopsy, high activity, maybe already some chronicity, we add then. And we're going to have choices now. We'll have Bulimimab. We'll have voclosporin. We could still, of course, use tacrolimus off-label. So now that we have choices and the choices are really quite safe, we're going to have to shift and be braver.
I was going to ask them to follow up on your question a minute ago about the hydroxychloroquine. Do you think there's any role for genetic testing of these patients to see if they've got maybe a single nucleotide pleomorphism or something that they might be more responsive to the drug, or maybe that's one of the reasons they may not be absorbing it properly, or some things like that? Are you guys using any genetic testing in lupus, systemic lupus patients, to see if there's some way you can correlate that with their responses to therapy?
You know, we can do that for drugs like azathioprine with TPMT testing. And the Koreans have actually published data on genetic polymorphisms that affect blood levels, but in Koreans. So right now we don't have the data on what all the genetic polymorphisms are. And if we did, it's always going to be the question of cost.
So we do have, let's just say we have sort of standard treatment for lupus nephritis as mycophenolate and Cytoxan. There are others, but let me put those two up. And now we have two newer agents, Bulimimab and voclosporin. Obviously, I think we're going to be forced to use conventional therapy, and those newer drugs are going to be secondary just because that's the way things work money-wise, insurance-wise. But is there a difference between the older and the new with regard to safety? Is that where the big benefit might lie?
So I think the good news is that we're not going to be adding a lot of safety concerns with these newer drugs. Voclosporin, as with any calcineurin inhibitor, you're going to have to know what the GFR is at baseline. And you're going to have to monitor the GFR because there are those rare patients who are going to have a reduction in GFR with a calcineurin inhibitor, and you would either stop the calcineurin inhibitor or reduce the dose. But, you know, my God, we've had Bulimimab now for 10 years. I don't think there are going to be any surprises, any safety concerns with Bulimimab. Now, I've always said Bulimimab has such a clean safety profile. It's incredible. And perhaps the reason it has such a clean safety profile is that it only reduces B cells by 50%. It's not so immunosuppressive that it greatly adds to any safety concern. Now, remember, we don't have enough data in pregnancy. I've been running that Bulimimab pregnancy registry for what seems like forever, and we still don't have enough data to promise safety in pregnancy.
Speaking of calcineurin inhibitors, Clay, in dermatology, they play a role in your management of either lupus or other diseases?
Yeah, I was going to kind of follow up on your question about, do you have to go through the lower steps on the ladder to get to the higher steps of the newer drugs that may be a little more expensive, the biologics? And I guess a better paradigm for us is in psoriasis. Years ago we would use ultraviolet light therapy and topical steroids and methotrexate. Now we're going straight to biologics. And even though they may be more expensive to use just kind of on an individual prescription basis, because of the efficacy is so fantastic. And some of these now are just given a couple times once a month or even less. It works out to be less expensive. So I'm wondering if you might have a similar kind of thing in the world of lupus, if you will, that maybe the paradigm might be to go to these drugs sooner rather than having to go through the systemic steroids and all the other stuff with the side effects and find, so, well, that didn't work. Now we finally get to use one of these other drugs.
So it's great to have a relationship with a dermatopathologist. I can call Clay any moment. My partner, when he got up to speak, she said, "Oh my God, Clay Cockrell, he exists. I thought he was like Quest and LabCorp. I didn't think he was real." I want to ask our Michelle and Maureen to maybe give a comment to Clay and find out from Clay about how you might do skin biopsies. I think rheumatologists, and this is just my view, I think we tend to do skin biopsies when I don't know what I'm looking at. That RAS thing that I'm not allowed to say. But do you have a different approach to when you do skin biopsies, or do you try to get them in everyone if to confirm the disease or maybe stage the disease? So what's your approach, Maureen?
I generally try to get them when I'm making an initial diagnosis. But I think that Clay brought up a very good point. If I have lesions that aren't improving, or just I think it's one thing and it doesn't seem to be responding the way I think that's another time where it's really important to get routine biopsies or another biopsy. But I don't tend to get them in every new rash that I see in a lupus patient if it seems to respond. How about you, Michelle?
So I agree. My patients with definitive lupus will sometimes get a new skin lesion that just doesn't fit. Mm-hmm. And, before I put a steroid or an antifungal on it, it would be nice to know for sure what I'm treating. But also, I so depend on my dermatology colleagues when I have recalcitrant disease in a patient, particularly true in discoid, where if I think the next step is thalidomide, I don't feel comfortable making that decision. And I will often turf it to my dermatology colleagues.
Clay, what's your advice for us as far as how we are doing it, and are we doing it right as far as what we're sending you?
Well, we see a few rheumatologists that do send us some pathology, and usually they're very thoughtful. They usually spend a little bit more time filling out the pathology form than a lot of the busy dermatologists, because they've really got a complicated case. And I personally enjoy working those cases up. I would encourage you to think about sending a clinical photograph to the dermatopathologist. That's very helpful. And, you always have to think when you're taking a biopsy, what stage of the disease am I looking at? Is the biopsy going to give me the highest yield? If you just kind of close your eyes and stick a punch into something, that's a lot less productive than if you say, well, this is a really erythematous area, or it's a really new lesion, indurated, something like that. And if you don't feel comfortable doing them, spend a little time with a dermatologist and kind of get savvy on how to do it. There's no reason that a rheumatologist couldn't do a biopsy. We get a lot of things from family physicians and others like that, and some of those guys actually send photographs along with it, and it's just, they can't maybe hit the same exact level as a dermatologist, but they can get pretty close if they've got good correlation there. So that's something you can do also to help you.
So Yin Hanlon asks about nail fold kaplaroscopy in lupus. Clay, you want to start with that? Do you do it? Does it have any predictive value?
It's interesting, and I would probably defer to the derm room type docs that really deal with that, looking at prognosis and things like that. But there are a couple of new devices now that you can actually look at the nail fold capillaries at a higher magnification. It's like a epiluminescence-like microscopy. And I think there is some information, some data now to show that based on some of the morphology, you can kind of assess the patient's activity of their disease somewhat. It makes sense that it would correlate with vascular damage that's going on, and if you can see that grossly with something that's non-invasive, I think there is some potential validity to it.
So my impression is that's very helpful in scleroderma and also in dermatomyositis, but I haven't been impressed as much, but I must say I don't do it as frequently in my lupus patients, even though they may have periungual erythema.
I don't think it's as common in lupus. I would
Sure.
agree with you. I think it's in the other diseases that it's more common.
Yeah, I also don't routinely check it, not as much as I do if I have a scleroderma patient. I'm not routinely doing it in my lupus patients. I haven't found it to be hugely helpful in my practice. Michelle, I don't know if you do anything.
Oh, I agree. We will see some lupus patients with periungual erythema, but rarely do we see, the huge capillaries that drop out that are so characteristic of scleroderma.
Who was it? Elvira Bangert asks, what are the mimickers of the V-type or shawl rash of dermatomyositis? What else can we give you a look like that?
Well, a lot of things can do it. And, dermatomyositis is interesting because it can show histologically some other findings than I showed you just on those slides. But just looking at that clinically, possibly a photoallergic drug reaction could give you that pattern. Sometimes contact dermatitis. There's a form of airborne contact dermatitis where certain allergens are in the air. They settle on the skin in the same sort of distribution where a photoallergic, where a photodermatitis would occur. So that can give you some changes that look like that. So that's a situation where it's, again, very helpful to get clinical information, a biopsy, ask them if they have muscle weakness, some things like that. You have to have a kind of a high index of suspicion. So if somebody comes in with something like that and they don't have a diagnosis of dermatomyositis, think to ask them some of those questions and maybe consider getting a blood test.
My partner, Catherine Dow, asked a question, but I'm going to spin it. She asked, please clarify, to achieve an SLE LL-DAS, what's the length of time a patient needs to be in LL-DAS? Is it dynamic and on the spot, or does it have to be for 3 months or 6 months? But then tell me, what clinical measures should we be doing in practice? I mean, I don't think people are doing LL-DASs. No, most people don't know what a bilag truly entails. Anybody want to take a stab at that?
Yeah, I'll take a stab at it. So, doing the LLDAS really incorporates the physician's global assessment. It also incorporates the SLEDAI. So you could look at that as either the last 10 days or the last 30 days. I think that when you look at the data with LLDAS, the LLDAS measurement was taken at each visit, and if a patient was in LLDAS at least 50% of the time, that seemed to have an impact on overall damage. So, I usually kind of will take a little quick measurement, but I do enough SLEDAIs in my practice that I can do that off the top of my head. So I do think it's helpful to incorporate SLEDAI. It's relatively quick. It's an imperfect tool. I think pairing it with physician's global assessment, which you can also do very quickly, is helpful, at least to have some kind of an objective measure of how your patients are doing. I certainly don't do bilag in my clinical practice. I think very few people would ever adopt trying to tackle that in a clinic visit. But I do think that as we move forward, just as in rheumatoid arthritis, it's going to be important to have objective measures that we can look at to see how patients are doing.
So what I do in practice is, of course I do the physician global assessment since I'm the one that published it. But please remember, it's on a 0 to 3 scale. It's not 100 millimeters, it's inches. 1 is mild, 2 is moderate, 3 is severe. So you can just do it in your head. But what I think is also helpful is to do it for the organ systems that you're monitoring in that patient. And that's what we published and called the Lupus Activity Index. But just think of it as, the visual is for the organ systems that matter in that patient. If they never had lung, if they never had skin, you wouldn't be trying to do a visual analog scale for something that wasn't pertinent. And the idea is just to keep everybody at mild or less. So really, the lupus low disease activity state is just sort of a common sense approach to lupus, paired with requiring that the prednisone always stay low.
Yes.
And we didn't require, when I did our cohort analysis, that the patient be in it at every visit. It was if they were in it at 50% of their visits, because remember, a patient might flare and you get them back under control, and a year later, maybe they flare again. So it doesn't have to be consecutive visits. It's just the majority of visits, they're in LL-DAS. You have reduced their future organ damage by 50%. And in particular, the really bad, what I call the high ticket items, you've reduced end stage renal disease, myocardial infarction, osteoporotic fractures. So no matter what happened before, remember Maureen's point, damage begets death. No matter what happened to that patient before, if you now reach that goal, 50% of their visits, you've still helped them immensely for their future.
So I want to do a little smackdown here. Michelle, you and I were in Dubai 2 years ago, and you blew my mind when you made a case for managing lupus without steroids. And I grew up in the era of Dr. Morris Ziff, who said, keep your lupus patients on a little bit all the time, 5 milligrams, and never go away from that. And you want to tell me and the audience maybe why I'm totally wrong?
Of course, I want to keep the daily prednisone dose below 6, Jack. And so, of course, I was the one that published that. It's not perfect, but if you can keep the daily prednisone dose at below 6 milligrams, you have reduced most, but not all, future organ damage. So even keeping at 5 or less, you've still increased later organ damage by 16%. And I actually think 16% might be livable. Not a perfect world, but what can we achieve right now with our armamentarium? But why can't we look for perfect? Isn't that what Treat to Target is all about? How can we be happy until we have a way to treat lupus without steroids? Now, I think one trap is that half of our lupus patients have the flare pattern. And they flare, it's rash, joint pleurisy, whatever. I'm not talking about life-threatening or organ-threatening flares. I'm talking about usual bread and butter lupus. Do we have to put them on oral prednisone for that? So that's why I did the float trial that showed if you just gave 100 milligrams of intramuscular triamcinolone, by the next day the patient's feeling better, and you did not have to put them on any oral prednisone. And so, we've now shown that those triamcinolone injections, as long as you don't give them more often than every 3 months, do not contribute to musculoskeletal damage like avascular necrosis risk. So I think for the flare pattern, we might be able to get away from oral prednisone altogether.
That'd be a great goal. Clay, has the spectrum of drugs that induce lupus, including SCLE, changed?
Not really dramatically. It's really about 4 or 5, I'd say, major offenders. We really see it most commonly, I'd say, in hydrochlorothiazide. So I don't think there's been a massive increase in influx of new drugs causing that. We do see some
I'm going to add proton pump inhibitors.
Yeah, PPIs, yeah.
Okay, because that's now in the label. I tell my patients, why won't you let me switch you to famotidine? Not just because I'm worried about the osteoporotic fractures, but now that we know that it's going to contribute to the risk of lupus rash. And yes, I am still concerned that proton pump inhibitors may not be best in patients that already have chronic kidney disease. So I think that rheumatologists need to have their antennae up when you see a patient who's on a proton pump inhibitor who's presenting to us with an SCLE rash.
A few quickies. Patients with a history of thrombosis or miscarriage, but only a lupus anticoagulant once positive, would you still treat? I think I would.
Okay, if this is a woman who's about to become pregnant, yes, I'm going to treat. Because if she has had previous losses, the guidance is to treat the next pregnancy. But also, if she has lupus, remember the research I published is lupus specific. We showed that if the lupus anticoagulant is present during the first trimester, it is a risk factor for a pregnancy loss in that pregnancy, even if it's her first one. So this idea that we have to wait for the woman to, lose a baby, that's what it is. I don't know why we call it miscarriage. The woman lost a baby. That's something that she's going to grieve about, for a long time. Some women never, ever get through that grief. So yes, of course I'm going to treat. And I think low molecular weight heparin and aspirin are very, very safe. I'm not worried that I'm going to cause a problem. And of course, I think everyone understands the low molecular weight heparin is not going to get across the placenta, so there's zero fetal risk. Now, if I pick it up just once, and I've shown you our data, if the person has lupus, even having it less than 25% of the visits, it is a risk factor for later thrombosis. Remember, my favorite regimen would be hydroxychloroquine, which hopefully she's getting anyway, right? And vitamin D, which I want women with lupus to get to achieve a 25 hydroxy vitamin D level 40. Don't have to go higher, never have to cause a toxic level. But please, everybody remember, if your patient's taking biotin, it completely messes up the vitamin D assay. It'll make it look high. And by the way, biotin messes up all the thyroid assays too. So you have to tell your patient who's taking biotin to stop it 1 week before their visit with you if you want to do blood work.
To get to a vitamin D of 40, are you doing daily dosing to get to that level, or are you going with 50,000 once or twice a week to get to that level?
I like the once a week because that way the patient's daily pill burden hasn't gone up. But Jack, there's some patients who just won't remember to take something once a week. So it's one of those shared decision-making things. I say to the patient, well, how do you want to do it? Right. You want to take it once a week, or you want to take, 5,000 every day? And then I get the patient to buy into it.
So John Tesser asked about the time to response within the 2 new drugs. Is that important to you? That maybe Bulimimab, the ability to get to a complete renal response was longer after 24 and getting out to 52. Maybe voclosporin was quicker. Is that at all important, the time to response, Maureen?
I think that does factor into it a little bit for me. Certainly, if I have a patient who's got quite a bit of proteinuria, I think I want to get that down below nephrotic levels as soon as I can. So in that circumstance, perhaps it's lean towards using voclosporin. I mean, ultimately, the most important thing is long-term outcomes, and I think that we've got, good data with both of those.
So let me add to Maureen's answer. It depends what number game you want to play. I think both of them have kicked in by 24 weeks. But if you want to look at the complete renal response at 12 months on the numbers, for that, Bulimimab is about 10 to 11%, voclosporin is about 18%. If you want to look, though, at GFR protection, the Bulimimab trial was 2 years, and it did show GFR protection in the Bulimimab arm. So I think it's going to be one of these things where, we're going to be very happy we have both, and there's going to be plenty of room for both. We're not used to this in lupus. This is more rheumatoid arthritis to have choices.
Wait,
We will have choices.
and there's more coming. Faster acting JAK or TYK inhibitors. Do you think that they're going to have a role in lupus management?
And wouldn't it be nice to have orals? Yes, I certainly hope they will. But I thought you were going to ask about obinutuzumab. Obinutuzumab is the better rituximab, son of or daughter of rituximab. Boy, did that look good in the phase 2.
It did.
And that would be, once and then it's 6 months. That would be really easy, wouldn't it? So I'm very hopeful that we're going to have a third choice for renal lupus.
I have 2 burning issues I want to cover in the few minutes we have left. One is I want to get your comments about what you learned during COVID and what you do in the COVID world. And maybe I'll better frame that in a second. But I want to first ask about, should we, rheumatologists all be working towards specialized lupus centers? Will we do a better job in, number one, addressing the ethnic disparities issue, the compliance issue, a comparison of a specialized lupus center versus generalized rheumatology clinics? They do better at monitoring things like lupus anticoagulant and a number of other things. We might have more appropriate skin biopsies and skin care. I think that rheumatologists are good at lupus, but when and Michelle, you're going to be biased, of course, but I'd like to hear from all 3 of our panelists about whether that's something we should make a serious effort to push for nationwide, or does it need to be just regional based on what's capable and how it will, I guess, be accepted? Maureen, why don't you start?
Yeah, so of course I think we are all going to have a little bit of a bias in the answer to this, but I think that lupus is a little bit different than some of the other things we care for in rheumatology. I think the patients can sometimes take a lot of time, and I think that the more lupus patients you're seeing, the more experience you have, the more tools you'll have to work with them, and I think that overall it's a little bit easier to provide the highest level of care when it's something that you have, that you see frequently and that you're really set up to take care of. So I do think that perhaps, if we had lupus centers, that may really help us have time to talk to patients about, patient shared decision making and get them to buy in on their treatments, et cetera. So yes, I think that it would be ideal to have lupus centers care for lupus patients.
Clay, your perspective as a dermatopathologist for a very large geographic area, you serve a lot of dermatologists, including those who specialize in lupus. What's your view on this? Well,
there's sort of a proxy that there are other types of skin disorders that we have multidisciplinary clinics, and they work very, very well, like lymphoma clinics for mycosis fungoides, things like that. And we have usually someone who's specialized in that. We may have an oncologist involved. We'll have a dermatopathologist that's there, often rotating in the clinic, so they can be very good. And I think lupus sounds like, at least from hearing from all you guys, that could be something that could be very valuable if we had something like that. We have a number of dermatologists here that have a very specialized interest in rheumatology, and they often end up getting all the patients sent to them in the area. So if you had like maybe a clinic that was set up that maybe these people staffed, and then maybe someone like me rotated through there periodically or saw these patients, I think it could definitely improve patient care.
So Michelle, this past week I published the results on Room Now of a survey asking rheumatologists, are you a super rheum? Meaning, are you devoted to just one disease only? And it's only about 1% of the 453 respondents claimed to really be a super room, and about half of those were lupus people like yourself. As someone who manages a lupus cohort of somewhere between 850 and 85,000, what's your view about, you've been successful doing what you're doing. You speak to a lot of people who'd like to do what you do. What's your advice?
Oh, I think practice makes perfect. And I am always kept humbled by the fact, I think I learned something new about lupus from one of my patients every week. You learn by missing something, and once you've missed it once, you remember it forevermore. So, I try to share the pearls, but I actually think that the Lupus Centers of Excellence, that our real role is to acquire data, analyze it, and that our focus should be the things that really matter in clinical practice. So I think that is my mission. And I actually think the super rooms are probably the general rheumatologists who are trying to remember everything about every single disease, because our field is marching forward so quickly. It is so hard to keep up.
We have time for one line from each of you. What's the greatest thing you've learned about COVID in the COVID era? Clay, do you want to start?
Well, one thing, telemedicine is overrated. And I think that Michelle, I guess, said that you can't take a blood pressure with telemedicine. And I've seen so many dermatologists that say, the imaging is not as good. If something even looks grossly pigmented, they need to come in to be seen live. And so, yeah, everybody wants to think that you can just look at an image like we're looking at right now with you two guys, that it's as good as looking at the patient, and sadly it's not. So it's not going to replace us seeing the patient in the flesh.
Michelle?
Oh, here's an example where I have to keep learning. I have to keep on top of the COVID research because it applies to our patients. So perhaps the most alarming thing I learned was that transplant patients, only the minority are making antibodies after vaccination. And that led me to change my practice. I now hold mycophenolate and methotrexate for a week after the vaccine and a week after the booster if they're getting the 2-shot ones, to try to allow my patients to mount a vaccine response. How awful it's going to be if I push to get my patients vaccinated, but it's not an effective response.
Maureen?
Yeah, so I'll actually give a little bit of the flip side. I certainly agree with the limits of telemedicine, but I'm actually glad that we now have it as a tool in our toolbox, because I have patients who live a little bit farther away, were only coming to see me infrequently, that I've at least had a little bit more contact with and feel that we're in a little bit closer touch, and I know what's going on with them a little more. So I will say that there are some upsides to telemedicine as well if we can incorporate it as part of our practice. As far as COVID goes, I think that even now our knowledge, I think, is really still evolving. And I am noticing, as with many infections, as I've seen more patients in the last few months here in Los Angeles that have gotten COVID infections, I'm certainly starting to see flares of disease, as I do, often with other viral infections as well. So again, I'm hoping with all our patients that we're really getting them vaccinated and getting some protection for them. And hopefully it will actually result in some protection, which I think is another evolving question, as Michelle pointed out.
One person asked about okay to vaccinate on Bulimimab, and I think the answer is yes, based on the experience.
Yes.
So
Yep.
It's not the same as rituximab. I want to thank our panel. Great discussion. Maureen, Michelle, Clay, thank you very much.
Thanks so much, everyone.